All right, good morning, everyone. Welcome to our quarterly training. Thanks for being with us today. This training today is titled Medi-Cal Mental Health and the State of State Fair Hearings, What Every Mental Health Advocate Should Know. And here today from the Access team, I'm Jocelyn Farrell. I'm our program coordinator. With us, we have Nicole Chilton, our program manager for Access California, Grace Gallagher, our communications coordinator, and Marco Ramos, our advocacy coordinator. And then for this presentation today, we're really honored and privileged to have Ted Mumford with us today. Ted is a senior staff attorney with the Legal Services of Northern California, where he's worked in their health unit for the last 4 years. Ted went to law school with the goal of becoming an advocate for underserved communities and quickly found himself as a legal aid lawyer assisting those like himself who live with mental health challenges. The majority of his work at Legal Services of Northern California now revolves around helping people stay on Medi-Cal and securing appropriate treatment for those on Medi-Cal who need mental health treatment. So we're really excited to have Ted with us today. I think this will be a great training. I'm looking forward to learning a lot from Ted as well. A little bit about Legal Services of Northern California. Their mission is to provide quality legal services that empower the poor to identify, and my screen is getting cut off here. Oops. Hang on one second. One moment here. Sorry about that, guys.
I would jump in if I could perfectly quote our mission
Okay.
statement, but
Sorry about that.
I'll let you read it.
Sorry. The mission of Legal Services of Northern California is to provide quality legal services that empower the poor to identify and defeat the causes and effects of poverty within their communities, efficiently utilizing all available resources. So a little bit of housekeeping before we begin. This training is scheduled for 2 hours. The training is being recorded and it will be made public on our YouTube channel. If you'd like to speak at any point, raise your hand. We will unmute you at an appropriate time. Feel free to add your comments to the chat box at any time and we'll respond to those at an appropriate time as well. We are also going to launch a demographic poll at the beginning of this presentation, and that will be to gather some basic information from you. And then just a few ground rules. We just ask that you honor yourself during this training. So practice self-care. If you need to step out for a moment, that's totally fine. You're welcome to do that. And just model the behaviors that you want to see in others. And then honor your fellow attendees. So assume good intent in others. People might share things in the chat that you disagree with, and that's totally fine, but assume good intent. Focus on the issues and the facts at hand rather than individuals. Look for areas of alignment, and if you do disagree, disagree respectfully. Try to be solution-oriented. And then we also ask that you keep your questions and your comments brief, just because we do have quite a few people on the training today and we want to be able to hear from as many people as possible. So just keep those brief so that we're able to answer as many questions and hear from as many people as we can. If you have other ground rules that you think would be helpful for the group, feel free to add them in the chat. And with that, I'm going to pass it over to Ted to begin his presentation, and I'll begin the poll. So again, thank you, Ted, for being here, and we're looking forward to your presentation. Ted, you can begin whenever you're ready. I'll leave the poll up for a few minutes, but whenever you'd like, you can begin. We can see your
Okay,
presentation
that
on our end.
sounds great. Hello, everyone. Good morning. My name is Ted Mumford. Pronouns are he and him. And as I was so graciously described, I am a staff attorney at the Legal Services in Northern California, where I have been for the last 4-ish years. And I'm giving this presentation because I want to explain how the law says the mental health system within Medi-Cal is supposed to work. That way, we all can sort of identify the differences between how it's supposed to work and how it actually is functioning. Because I think most of us in this virtual room will have some experience with the mental health system, whether that be by helping someone else navigate it or by navigating it themselves. And Medi-Cal does not make this easy. I think for a lot of advocates, even those who have worked in the system for a long time, there may be some new things here that I'm going to be talking about. But there should also be a lot of familiar things. A lot of things that people think they know about the mental health system are true. A lot of things that people think they know about the mental health system are not true. And so I want to hopefully give a good overview of what it's supposed to look like, what the entitlements that people on Medi-Cal have, and then also what we do about it. Like if the county or a mental health system is violating a patient's rights, what do you do about it? So who am I? We talked about it a little bit, but I'm a staff attorney at Lisnick. We're a nonprofit law firm. We've been around for about 70 years, receiving both federal and state funding primarily as our primary sources of revenue. We have 8 offices throughout Northern California, and we serve 23 counties within our traditional service area. That's that dark blue area on the map there. And then the light blue area is an additional 9 counties that we serve with health-only grant funding. So me being on our health unit, I'm representing people in 32 different counties across California. And our health unit is taking in something like 3,000 cases a year. And so we're advising individual clients. We are negotiating with counties and their Medi-Cal plans and others to make sure that they get access to the care that they need. And then we're representing those individuals in state fair hearings, in appeals, and other levels of advocacy. And then at times we're also litigating issues. So we are filing lawsuits on behalf of low-income people to ensure that not only those individual people get the services that they need, but if that failure to give that individual is maybe part of a larger story, part of a real systemic problem that's facing a lot of people, we will litigate to hopefully solve that problem for quite a few folks. And then I listed one case that I'm currently working on, Emily Doe v. Sacramento County et al. It's a case we filed last year against Sacramento County and a couple state agencies. And so I'll be talking about that a bit because it's informed a lot of the work that I do. And it's also, I think, illustrative of what the counties and the state think of when they think of mental health and what people are entitled to, and maybe some of the ways that we can push back and we have pushed back, and hopefully some of the things that are going to be improving in the future. And then a little bit more about Lisnick. Not only do we do health, but we also work on public benefits and housing issues. We dabble in education rights and expungements as well. But our 3 primary areas are health, public benefits, and housing. Most of our attorneys, I think, spend most of their time on housing issues. So these are primarily evictions and Section 8 issues. And then, but we all do all of the things. I just wrapped up an eviction case not too long ago. I have a general assistance case I'm working on. I've done CalFresh cases before. I've done CalWorks cases before. I've done IHSS cases. So do a lot of the various public benefits that we have here in California and make sure that poor people actually get access to them. So the agenda for today, we're going to start out with just an overview of Medi-Cal mental health, what the system looks like, how it's supposed to run. We're going to talk about specifically the specialty mental health care services in Medi-Cal, because that is an area where there's a bit of confusion and a little bit of a black box for even a lot of our mental health providers who are working in that system. They don't always know how it works. And then we're going to talk about what we do when there's a problem. How do you challenge the denial of a service or a delay of a service or some other issue that patients run into on a regular basis? And if you want to challenge it, what does a state fair hearing look like? What is that process like? I've done a number of them myself. We do a number of them at our firm all the time. So hopefully it can give some insight there for anyone who's maybe representing themselves or who might want to know more about that process because they want to refer someone to us. And then the last part of our agenda, we'll be talking about the case referral process. So if you're an individual who works with people who are on Medi-Cal and need mental health services or any other service really, how do you get them to us? And if you're an individual yourself that's looking for services, how do you get to us? So we'll talk about all of that. The goals today, I want to learn about mental health services, which ones are available to youth and adults? What's that menu of options? I want us to identify common legal and practical barriers to accessing mental health supports. I want us to learn how to ask for services that are needed. And I want to learn how to challenge those situations where services aren't given that are needed, and what's the plan for referring cases to LISNEC or to others if you're in a different county and not one of our 32. Okay, so here's my first section. This is Medi-Cal Mental Health 101. Buckle in, get ready. And we're going to have questions at the end of each subsection. So I'm going to have this Mental Health Medi-Cal 101 section, and then we'll do questions here at the end of the section, and then we'll do the same for the next few sections. So the first thing that I tell every new advocate that works for us, any client who's calling us, is that Medi-Cal is required to cover all medically necessary services. Very frequently, doctors who work within Medi-Cal, therapists who work within Medi-Cal, patients who've been on Medi-Cal maybe for years, think that there is a very limited number of things that Medi-Cal will cover. And it is simply just not true. Like, legally speaking, Medi-Cal has one of the most expansive array of services that they can provide individual people. So this means when I say medically necessary, the legal definition is when it is reasonable and necessary to protect life, to prevent significant illness or significant disability, or to alleviate severe pain. And over the last few decades, many of the laws that regulate our private insurance companies have gotten closer to this standard, but it's not nearly as broad or generous as the Medi-Cal standard is. So it means that even if your health insurance company says, sorry, we don't provide that service, or sorry, we don't have that specific type of equine therapy that you need, if your doctors say you need it and you can prove that you need it, they have to pay for it and find it for you. And it also means that there's things that are necessary that aren't necessarily even medical services. For a long time, we fought to make sure that transportation was a benefit within Medi-Cal, because a necessity for many people on Medi-Cal to getting a medical service is transportation to get there. And a handful of years ago, we with some help from some supporters of ours, got a bill passed in the legislature that guaranteed the right to transportation for all Medi-Cal members. And that means not just ambulance transportation, but also a ride from your home to the pharmacy and then back home, or from your home to your doctor's office and then back home, or to any other Medi-Cal related service. And so I really want to start here just to say that Medi-Cal covers all medically necessary services. I will say that like 100 more times in this training. But when someone says, sorry, that's just not provided by us, question is it necessary? Not, is this something we have already contracted with and have it in our system already? And then what does Medi-Cal cover in the sense of like referrals and HMOs versus PPOs? And a lot of those letters are thrown around. But I want to just put this here as a starting place. With all insurance, every insurance has slightly different rules, but the general rule within Medi-Cal is that specialty services require a referral from a primary treating physician or provider, and non-specialists do not require a referral. And this is more obvious in the healthcare space because you've got a primary care doctor, and then you've got your specialists that are your orthopedic surgeon, your endocrinologist, so on. And that system, I think, is very familiar to a lot of people. But in the mental health space, it's a little bit less clear. Non-specialists are your therapists. They are your social workers. They're the people that you might talk to once a week for an hour in an outpatient setting. They are technically like your PCP in the mental health system. And you don't need a referral to go there. You can just call them up, make sure they take your insurance, and go. And then specialists are psychiatrists, and they are intensive outpatient programs, and they're other types of specialty treatments that do require a referral. So I just want to put that there as a kind of an overview of just sort of how one might navigate this and what are the big picture items. Now, here's where we get into how Medi-Cal mental health is very different from almost every other mental health insurance system. It's bifurcated. There is two separate and unequal systems that provide mental health services to people on Medi-Cal. There's the managed care plan. That's the thing that most people are familiar with. They interact with. They're brand name companies. They're your Anthems, your Health Nets, your Kaisers, your partnerships. When you are on Medi-Cal, you are assigned to a managed care plan. And you're going to know it. You're going to get a card with the picture and the logo on it and everything else. But then there's this separate system, and that's called the County Mental Health Plan. And it's very frequently known as like the County Department of Behavioral Health. So here in Sacramento, it's Sacramento County Department of Behavioral Health. And they will do both mental health treatment and also substance use disorder treatment. And oops, trying to advance the slide. And the difference between these is that in the managed care plan is designed to provide services to those who have mild to moderate symptoms. And the county mental health plan is designed to provide services to those with moderate to severe symptoms. And I'm going to talk on this a little bit more later, but you have to think of this as a spectrum. And somewhere along the line, someone's going to tell you whether you go in one or the other. And it's not always clear because that moderate chunk is probably where a lot of people, if not the majority of people, land. And so it's not always clear whether you're supposed to be going to the county or you're supposed to be going through your managed care plan to get your mental health services. When I say managed care plan, think outpatient talk therapy, think outpatient psychiatric medication management, think psychological testing. That's kind of the basics. There's a few others that I could probably throw in, but that's mostly what people are, the main things that people are interacting with. So it's talking to a therapist once a week or once every other week. It's seeing a psychiatrist to get your anti-anxiety or antidepressant prescribed to you. And it is getting some kind of maybe psychological testing if you're suspected of having a developmental disability. That's basically what the managed care plan's mental health treatments are limited to. On the other hand, the county provides a lot more things. So if you are in that, I think it's on my next, no. If you are in that moderate to severe category and you are deemed within the realm of the county mental health plan, so within your county behavioral health department, this is the list of services, and again, non-exhaustive list, but this is the list of services that the county could provide. And these are not my words, these are words that are given by the state and by our legislature, but they say mental health services. Like, what does that mean? There is a definition, but it is quite broad. But it includes crisis stabilization services, crisis residential treatment services, it includes medication support, psychiatric inpatient hospital services. So that's like you go to the ER and then they discharge you to a psych hospital, both the ER visit for a 5150 or some sort of psychiatric hold, and the psychiatric hospital where you're then discharged to would both be paid for by your county mental health plan. And for most people who interact with that system, they never know about this. Like they're on Medi-Cal, they never see the bill, they don't know who pays it, but the county is the one that's paying it. And the county is the one who's responsible for paying those relatively expensive hospital bills for you. But then there's supposed to be a whole host of other services that they can provide you as well. For many of my clients, they will cycle in and out of ERs and psychiatric hospitals with various behavioral challenges and never get connected to the rest of the services. Even though the county's paying for these really expensive hospital services, they keep bouncing in and out and never get connected to your outpatient therapist or an intensive outpatient program, a partial hospitalization program, or anything else that would maybe bridge the gap and help someone get back on their feet after a hospitalization. And so these are the services, but again, it's medically necessary. So if there's something on this list, or if there's something that's not on this list that your doctors say you need, we can make an argument that you need it, and the county or the state or your health plan has to pay for it. The term of art, like I put it in quotes, especially mental health care services, SMHS. That's the name of the type of services that the county provides. So that's that moderate to severe level uh, uh, behaviors that someone might exhibit that are then treated with this menu of options. There are additional services for beneficiaries under 21. So if you're on Medi-Cal and you are under 21, you got a few extra things you get. And this is the result of federal law, which sets the standard for medical necessity for kids a little bit broader. And it's the result of some lawsuits that have been filed over the last couple decades about making sure that kids have more flexible and cohesive mental health care services. So that's therapeutic behavioral services, otherwise known as TBS, intensive care coordination or ICC, therapeutic foster care, and intensive home-based services, HBS. Many foster kids or parents of foster children or advocates for foster children will be very familiar with these four because they're almost by default given to a lot of kids in foster care. And then I want to mention too, I starred some of the services on that list. Sorry. I starred them because they are very common services in the private world, the private insurance world, but very rare services in the Medi-Cal world. Crisis residential treatment services is like a residential mental health program where you might live at a mental health facility for a number of months, where you'd get pretty much round the clock treatment, care, and also supervision if you're someone who might be at risk of harming themselves or others. It's not that it's super common for people to go to these centers, but they are commonly available. There's facilities like this all over the state, all over the country that provide these services. And if you have private insurance, your private insurance company likely knows which ones to connect you with. But if you ask for that service and you're on Medi-Cal, the county will look at you like they have no idea what you're talking about, and they've never provided these services to anyone. The other two services like that are day treatment intensive services, and that's one way of saying an intensive outpatient program. So that's generally 3 hours a day, 5 days a week of therapy, psychiatry, skill building treatments, therapies that are provided in an outpatient setting. So you go into a therapy office and you'd be getting a whole host of services for like 3 hours a day, 5 days a week. And it's a fairly common next step for people with mental health issues. If you exceed the sort of scope of what just normal once a week or twice a week therapy can provide, you're generally recommended to go to an IOP program. But if you are a Medi-Cal patient, that's just not an option in many counties. And it's not that it's legally not an option. It's the counties are violating the law by not providing these services when people need it. But it is common that counties will say, sorry, we don't provide that. And the same with psychiatric health facility services, which is akin to partial hospitalization programs, which many of us might be familiar with. I'm going to take a pause here before I go into a little bit more. This isn't a normal stopping point, but I've been yapping, and I want to see if there's any other questions right now about sort of the menu of treatment options and the general rule of medical necessity.
There's a few questions in the chat. The first one from Zoe. Is there a way that people can be notified of all the services they're eligible to receive based on their needs?
Yes, we will get to that, but it's called the assessment process. And technically, the county or the managed care plan are both required to do an assessment. If someone were to ask for mental health services, they have to assess you and determine what types of services you're eligible for.
And then a follow-up from her says, some issues I've run into, and I'm sure others have too, is that there are not enough providers to meet the need, even if the individual or family gets approved for treatment. So how do eligible people access those services?
Oh, we'll go into that too. A lot of the oh, there's no one available is like, oh, we're like not willing to pay providers enough. And so if you push back against county or your managed care plan, often they will find someone. Even if they yesterday said that there was no one, they will magically find someone the next day if you push hard enough. In some of our rural areas, that can be trickier, of course. Telehealth has helped, but there are providers available and you're entitled to those services if they're medically necessary. So we'll talk about all that more, but that's a really good question.
Sarisa also put some questions in the chat. She also has her hand raised though. So Sarisa, if you want to come off mute and ask those questions, and correct me if I'm saying your name wrong too, please.
No, it's okay. Thank you. Yeah, it's Sarissa. One of my questions, kind of going back to when you said, like, the law says, they have to provide mental health. And then when you go to the county, some counties don't provide it, or it's not accessible, whatever. How do we find out what those norms are compared to like federal, state, and then county? How do we navigate that? Like, how do we dig in and actually get those answers of, for example, family therapy is one of them. We looked into it. It said at a state level, it is a covered provided benefit. At a county level, we hit every roadblock. We even went as far as asking the judge to court order family therapy, showed that to the insurance and showed that to the doctors, and they still were not willing to cover it. So I'm experiencing that discrepancy between state and federal law, state law compared to county law. How do we get the information that we need of why it's not covered, so we can actually start doing some advocating on that?
That is such a good question. We're going to talk about this a lot in just a bit. So hold tight. And I hope to answer all those questions, but if I don't, raise your hand again, of course.
Thank you.
And the last hand up is from Pat. Pat, if you'd like to come off mute.
Hi, thank you. I have the impression, I'm in San Mateo County, so I believe that our behavioral health services does offer all of the things you have asterisks. Is that true?
I wouldn't be surprised. San Mateo stands out as a shining star amongst counties and providing benefits to low-income people. So that would not surprise me to hear that they are providing those services. I don't know for sure, but very well could be. Okay, I'm gonna move on, unless there's anybody else. I got or no. Okay, cool. I'll keep going. All right. So here's our timeline. I like to use a timeline to sort of describe the steps because it's very easy to get lost in this process, even if you've done it many times yourself. I will be advising clients sometimes, and I get lost in this in the sauce in the system in this process. So, like I mentioned before, the first step to getting mental health services through Medi-Cal is to ask. You just got to ask, and that can be. Let's pretend you've got a Kaiser managed care plan. You could call Kaiser Member Services and say, hey, I want to talk to a therapist. They then have to set you up with a therapy appointment to assess your level of need. That's step two. And then you get to that assessment. And then in that assessment, they would be determining, are you someone with mild to moderate needs, or are you someone with moderate to severe needs? If you're in the severe category, we're going to refer you over to the county. And if you're in the mild to moderate area, we're going to keep you in-house, and we're going to make sure you get the therapist and whatever other treatments you need. Part of it, I have step 3 of the treatment plan because it used to be a separate requirement that the assessment would be separate from the treatment plan. It's now kind of combined. So generally at that assessment, they will also develop a plan. It's part of a standardized assessment process that tells the patient what types of treatments the provider is recommending. So they'll say, we recommend the patient sees an outpatient therapist providing cognitive behavioral therapy twice a week, and in addition, seeing a psychiatrist for potential consult on medication management. That might be in the assessment. It also might be that we recommend like full wraparound in-home behavioral services for 3 hours a week, in addition to 2 hours a week of therapy at school, in addition to a family therapist that's working with the parents and the child, and psychiatric medication management. It could be a whole list of things, and it could even include contingencies like, hey, we're going to provide all these things, and if it doesn't work, we're going to reassess to provide maybe something else. And then step 4 is you hopefully get the service. So after that assessment, and as part of the assessment, the plan is developed, you should be able to get the services. I had one of our regional councils here at LISNIC, who has done HealthLaw a lot longer than me, has used the sorting hat analogy that I love. It's simple, but I think it sticks with me, at least. It sticks in my brain. So the assessment process is like the Harry Potter Hogwarts sorting hat. It determines whether you're going to the managed care plan or you're going to the county mental health plan. So you ask for mental health services. That's the request. Step 2, sorting hat. The sorting hat tells you, are you going to the county or are you going to your managed care plan? And then you get a treatment plan, and then you're getting services at the appropriate, from the appropriate entity, whether that's your Kaiser or your county. So here again is the same chart I've used before. I crossed out separate systems. I put in Hogwarts houses. It's very silly, and I was trying to be funny, and I don't know if that's funny. It's mild to moderate, moderate to severe. I think we all get it, but in case you don't, here it is again. And then the assessment process should do 3 things. 1, there should be no wrong door. You should be able to go either to your county or to your managed care plan, and they should be able to do the assessment to determine which one you go to. They should also be able to tell you what level of impairment you're at. Are you someone who has relatively minor symptoms and you can easily be served with going to therapy once a week, or are you someone with pretty severe symptoms that might need pretty intensive services? That assessment should tell you that. And then it should also tell you the specific types of services you need. The best assessments will say, this person has these strengths and these weaknesses. It'll say, this person has had this history of treatment in the past. And then it'll recommend a very specific type of therapy, and even like a modality, like a cognitive behavioral therapy or a DBT or group therapies or some other more specific description of the type of therapy you need. The worst assessments will barely give you that. And that can be a really frustrating point for many patients and for many of my clients when we get to the assessment, but the assessment's just not very specific. And so I've asked providers that I work with, hey, I really appreciate the assessment you put together, but could we be a little bit more specific so that I can make sure I'm getting what you think I need? So here's the mental request timeline again. And then here's some common barriers that we see a lot. So the hot potato, that's where you ask for services, for mental health services, and you get bounced back and forth. So you go to Kaiser, you say, hey, Kaiser, I really want a therapist. And they say, okay, well, we're looking at you and we don't think that you have mild to moderate symptoms. You seem to have like pretty severe needs. Go to the county. Then you go to the county and you call them up and you say, hey, I'd like an assessment. And the county says, no, your symptoms aren't that severe. You need to go back to your managed care plan. And then you go back to your managed care plan and they say the same thing and you bounce back and forth. I have seen that happen less often lately, but it does happen, and it has historically happened quite a lot. And you can imagine too, like the time period could be quite a long period of time. You might finally get up the energy to look for mental health treatment, be told, no, I can't get it from this place. And then you put a pause on it because your life happens and you're not able to move to the next step very quickly. So then 3 months go by, then you go to the county, then you ask for an assessment, then 3 months might go by again before you reach out to your managed care plan again. So it can be a long-term game of hot potato that really puts patients in a bad spot. The next that I think a lot of people have experienced, and I talked about earlier, is services aren't available. I'm sorry, but Sacramento County just doesn't have that service. What I always say is, I don't care if you don't have it now, you can get it. It's not impossible. Other people can get this service, so can you, Sacramento County. So that again, is a common barrier. We push back on it with evidence that it is in fact necessary for the person. Another barrier is no assessment. So the person goes to the county and they ask for an assessment and they don't get one. Either they don't have someone available that day, or they, I've heard all sorts of wacky stuff. I had clients who were trying to get mental health treatment from Humboldt County, go to their mental health office, and we're told, sorry, like our wait list is really, really backed up. Like you shouldn't get an assessment here. You should go somewhere else. Like go to your managed care plan, talk to somebody else. And I think that front desk person was really trying to do the right thing for that person. But what it meant was that this person did not get an assessment, which they were entitled to get, because the county says that they didn't have enough providers. The next one is a bad assessment. So I talked about this before. It's usually vague. The assessment itself just won't be specific enough. I can't, if you say this person needs therapy, but don't say what kind, if the county gives you, individual therapy and you needed group therapy, or the county gives you once a month therapy and you needed everyday therapy, like those are very different things. And if the assessment is not specific enough, it's really hard to push back against the county to say, hey, follow your assessment. It's here. It says that this is what they need. Continuity of care, that's a very tricky problem. This is when someone is on one insurance, they switch insurance plans, and they lose their healthcare providers. So let's say you're working and then you have a mental health crisis. You're maybe seeing a therapist through your employer's insurance, and suddenly you lose your employer insurance because you lose your job. And then you're like, well, what do I do now? I don't have that same insurance. I can't continue to go back to that same therapist. I'm now on Medi-Cal. What do I do? And theoretically, Medi-Cal is supposed to pay for continuing coverage with that provider through a term of art called continuity of care. It doesn't always happen. It can be very difficult to get for a variety of reasons, but that can be a problem. It can also be a problem when you're even working with the county for a long period of time with a therapist or with a psychiatrist, and that psychiatrist leaves, like they retire or they move to a different area or whatever. Like what do you do then? I have many clients who just sort of drop off from treatment because they really trusted this person and they don't feel comfortable going to someone else, or they liked the person they worked with fine, but then after the person left, they were never given a call to schedule a new appointment to initiate services of someone else. So that can be an issue. And then the last is my favorite topic. It's long wait times. It's we hear so frequently that the next available therapist appointment is 2 months away, or 3 months away, or 6 months away, or in Humboldt County, I've heard 9 months away. And the same thing with psychiatry. Like, sorry, like we don't have any psychiatrists here who can see you for the next month. That's just not okay. The law is very, very clear on this issue. And it says that for that primary level mental health care, you're entitled to that appointment within 10 business days of your request and 15 business days of a request for a specialist. So it's 2 to 3 weeks. And the insurance company or the county is the one that's responsible for making sure that they have enough providers to offer that. You can't force, of course, any individual therapist to just magically open up time in their schedules for you to do this, but you're entitled to a therapist or a psychiatrist who can treat your need. So it can be a little bit tricky, but we're going to talk about this a lot more in the next section. So if you have questions on wait times and timely access, I recommend holding them off. But here's another time for questions if anybody has questions about the timeline of the process of requesting treatment and then finally getting it, or about the assessment process or the common barriers. Any questions about those?
Sarissa, you can go ahead and unmute yourself.
Hi. Yes. With the assessment process. So, is that supposed to be documented in our medical records? So should we, like you said, in a timely manner, they have to provide a psychiatrist or a therapist, and if we don't, if we have a differences of treatment or whatever, and I eventually want to separate, what are our rights to make sure that the assessment results are included in the records, so any future provider has access to that so they can understand, you know, historically, you know, what my diagnosis was, etc.
Yeah, it can be sometimes tricky to get medical records for a variety of reasons. The assessment should always be part of your medical records. It's not always given to the patient, and they're not required to give it to the patient just without asking, just as a default. So you often have to ask for it. There are some exceptions in the mental health space. So generally speaking, patients have the right to access their own medical records. That was part of the Affordable Care Act. So anytime you go to the doctor, you should be able to get those records. There's an exception within the mental health space if the provider believes that their notes or their records might cause you some kind of psychological harm by reading them. And they can legally withhold those records from your view. And so that can be a really, really tricky, sticky situation where the provider has a duty not to share it because they think it's going to harm you, and the patient wants it, often for a very good reason. And there's no real mechanism to resolve that dispute. And so without just obviously like suing that doctor, but that's not something that's accessible for most people. Yeah, sir. So you have a follow-up question?
Yeah, I do on that. So I actually had that experience where I was requesting my medical records because I was trying to understand their decision and they weren't communicating clear. So I'm trying. I have ADHD, so I can talk a lot. I'm trying to simplify it. So they declined it under that pretension, like you said, it's a law that you know, based on mental health, they're afraid it might trigger me or whatever. Am I entitled to a written decision? Or is that just something that they can mentally say, oh, nope, not on this patient. I'm not giving them their records. I'm afraid that it might make their situation, their mental health unstable. Or do they have to provide that in a written letter or at least in my medical records where I can at least get a copy of that, of their decision?
As far as I know, there is no law that requires providers to give a written reason why they're withholding your medical records. I don't spend a lot of time working on the medical record side of things, so I could be wrong. But I don't think I've never seen a written notice, and so I don't think that there is one. There are requirements that we'll talk about in a bit about the insurance company's requirement to send you a written notice when they are not providing a service. So if you're asking for a service and they're not providing it to you, or you're asking, or your doctor's asking for a service and they're not providing it to you, you have to get a written notice about that. But the actual reason for not handing over the medical records, I don't think so.
Okay. And then how relevant is the assessments in terms of taking it to doctors? So like say for example, we see only a doctor for like 3 weeks or 6 weeks or whatever. They did an assessment, found we have something, and then we move on. Do we start that assessment process over, or or is there some type, because like I don't want to continue to keep wasting the state's money to keep administering the same test over and over when, you know what I mean? Like
Yeah.
can you adopt this? Is there like a key word that I should be using?
Generally speaking, most clinicians will ask for medical records of past assessments to help them do their assessment. It'll save them time. It'll also give them, of course, just more information. And so it's frequent that these clinicians who are doing the assessments will ask for like a release of medical information, and then they'll send that to a previous provider to get a copy of the assessment. So even if that old provider said, hey, sorry, like I can't give this to you because I think it may cause some kind of psychological harm, they might be able to provide it to your new therapist so that the new therapist or the new clinician of some kind has access to those records so they can continue treating you, even though the information didn't pass from them to you to them. It went directly to them. So that's pretty common. And they don't necessarily need to do a full new assessment. They often are, again, relying on assessments that have been previously done.
Appreciate your help. Thank you.
You're welcome. Any other questions for this section? Okay, let's keep going. All right, so here's where we talk about patient rights. And these aren't the patient rights that I think a lot of people talk about or think about. These are the patient rights in terms of what's your right to care from an insurance company. So Medi-Cal members have an entitlement, and I care about entitlements because I'm a lawyer, but it's also, I care about entitlements because it's like, these are the things you can force someone to give you. Um, you're entitled as a Medi-Cal member to medically necessary services. We talked about that before. You're entitled to a standardized assessment, and you're entitled to timely access to the care that's determined in that assessment, or is determined in some other way as well. We're going to go through each of these. So what is medical necessity? We gave the definition earlier. It's a service. Service is medically necessary when it is reasonable, necessary to protect life, to prevent significant illness or significant disability, or to alleviate severe pain. It's in state law. It's easy to quote, sometimes a little bit difficult to understand or to explain to a judge, but it is in law. For children, I had mentioned earlier, the standard's a little bit different. Medical necessity for children means something very specific. It's early and periodic screening, diagnostic, and treatment services. So not only is it the services that might alleviate pain or prevent significant illness, but it's also those services that might screen for issues or diagnose issues or and treat services. And the services for children need not be curative or restorative, meaning they don't need to actually get you back to a baseline. They just need to sustain, support, improve, or make more tolerable a mental health condition. So that barrier for children is much lower than for adults, and theoretically children should have even easier access to more services than adults do under Medi-Cal.
And can you write that in the chat? So that's important. I think we should know that.
Sure. If someone could copy that in the chat for me, that would be great. Otherwise, I think I can give you access to the slides, or this is recorded. So reach out to, or we can reach out to me at the end. I'll give you my email address.
Okay, thank you.
I'm going to go a couple more slides, or maybe actually I'm going to finish this slide and then I'll take some more questions. Timely access. So timely access is an elusive thing. It is in law, and it's pretty darn clear, but very few people actually experience it and get the benefits of it. So if you need an urgent service, the county or your managed care plan has to provide that service within 48 hours. If your urgent service requires some kind of prior authorization, they have to give it to you within 96 hours. If you have a non-urgent need, and when I say urgent, I mean like this is something where waiting more than 48 hours is going to significantly harm you. But if it's a non-urgent need to see a specialist, like a psychiatrist, your mental health plan through the county or your managed care plan through the company is required to provide you with that psychiatrist within 15 days of the request for the appointment. So if on day one, I ask for a psychiatry appointment, they have to give it to you within 15 days. And if they don't, they have to send you a letter saying that they didn't provide it to you within 15 days, and you can appeal that. We'll talk about that more. And then non-urgent appointments with non-physician mental health care providers. So that's therapists mainly, but it's also caseworkers and social workers and the rest. You're entitled to that appointment within 10 business days of the request. And I've sued a couple counties on this issue because counties tend to be very bad at this. The managed care plans, somewhat less so because they have just larger networks, but the counties are pretty bad about giving that. And then non-urgent appointments for ancillary services. So this is lots of other things that aren't necessarily your front of the line psychiatrist or therapy appointment. That's your 15-day window as well. So it's the same as the specialist physicians. And in each of these, it describes like an exception. It says, except as provided in CCR 1300.67. That exception is that a licensed clinician has evaluated you and determined that a longer wait time will not harm you. And in my experience, I have never seen a physician ever or a clinician ever evaluate someone and determine that, because the reason that the plans are not able to provide services quickly enough is not because they've made some conscious choice that you don't need it. It's because they don't have the providers. So they also don't have the providers available to meet with you, to evaluate you, to determine that you're okay to wait a little bit longer. So that exception is very rarely applied. Okay, so I will stop off there. So we're going to talk about how to actually challenge some of these things and enforce your rights. But in terms of rights, either medical necessity or timely access, do you have any questions? So I see Sarissa again. You want to?
Hi, sorry, I do. I'm very passionate. This is my,
I love it.
Okay, so with that physician or the licensed person to do the assessment if they can wait or not, would that be in like real time, like in Sacramento County? We have the the county access team, and they have those clinical social workers over the phone asking questions. Is that equal? I don't have probably the right terms, but is that equal to that of having a licensed person, trained person to be able to assess if they can wait or not?
I know exactly what you're talking about, right? You call in and they screen you. They have a number of questions they ask you, and it's usually like about, are you at risk of harming yourself or someone else in the immediate future and that sort of thing.
Yeah.
I have never seen Sacramento County use that as a justification for a longer appointment time. And those questions are so quick and brief that I don't think they could get enough information, but the answer is not super clear. So I don't know for sure if this ever got to a judge, what a judge would say on that. But the primary purpose of those screening questions is to say, do you need to go to the ER? Do you need something right now? Or can you wait for a normal assessment within the week or within 2 weeks?
No, it's actually not that question.
Okay.
In our experience where we've done the intake, and they ask you, why are you getting services, blah, blah, blah. And then they'll be like, we're going to transfer you to a licensed clinical social worker. She's going to do further evaluation, and then she'll let you know. And then once we review the case, we'll get back to you. So is that when they transfer us off to that higher level licensed clinical social worker, is that equal position of somebody being able to evaluate and say, yes, they need urgent, no, they can wait?
When they pass you off, how long is the meeting? Is it like an hour?
Oh, no, probably like 15-ish, 20, sometimes 30 minutes, maybe.
I think they're doing that initial assessment to determine whether you're appropriate for the county or appropriate for your managed care plan.
Okay. Okay. That's good to know. Okay.
Yeah, I think that's what they're determining there. Every county does everything just a little bit differently, which makes it very confusing for people who move between counties. But yeah, I think that's what's going on.
So how do we access then? Where do we go to get the access of an evaluation by an appropriate professional to determine if waiting or urgent is needed?
They generally don't. What I was trying to say was that they don't do it. They don't ever do it. So because they're not doing it, you're entitled to that 10 or 15 days.
Oh, perfect. Okay. Okay. Makes sense. Thank you.
Any other questions? Can someone see in the chat for me if there's anything there?
Can I ask one more question?
Sure.
Okay, sorry. So are you going to discuss what we do when we find out that they are violating those timelines?
Heck yeah. Yeah, that's my next section.
Okay.
Pat, I see a hand.
I was just trying to map what age you showed as the youth went for the youth.
It's
21 years.
21.
Okay, so in San Mateo County, we consider youth being up to 25 years old. So is that, or they call it transitional youth, but they're still lined up in the youth category even though they're 25. So I don't know that. I'm sort of like thinking of what you have here and kind of mapping it to what's considered youth by.
Yeah, I think that might be San Mateo going above and beyond and providing services they aren't even required to the group of people who are like 21 to 25, as you said.
Yeah. It's 18 to 25 is what they consider the transitional youth.
Yeah, there are also a transitional age youth set of services through the foster care system too. So that may be also what's going on there.
Okay, thanks.
Sarissa?
Yes, hi. So what about children that may have dual diagnoses? So
Like a developmental disability and a mental health condition?
yeah, or a pretty severe like learning, or in my daughter's case, a pretty severe medical condition that does
Great
impact
question.
the brain. So that,
Great question.
yeah.
Uh, so earlier I talked about the hot potato between the managed care plan and the county mental health plan. There's a second game of hot potato that we played if the child or the adult has a developmental disability, and that's between the regional center and the county mental health plan. So it can be difficult to sort of parse out which behaviors are mental health, which behaviors are developmental, and then which treatments might work for an individual person, right? Like everyone's going to be a little bit different. And so there can be a game of pushing the person back and forth between that other system as well, which can be extra tricky. But if the person has a diagnosed mental health condition and there is a mental health treatment that would benefit them, they would be entitled to it through this mental health system that we've been talking about today. Okay, not seeing any other questions, so I'm
Oh, there's a question in the chat.
Oh, thank you, Marco. Could you read the question for me?
What if you're asking for services, but they tell you that they can't approve it because there are no other patients, because there are other patients that are worse off than you? For example, a few years ago when I was experiencing increasing suicidal thoughts and was concerned and asked my therapist for an IOP referral, and his response was that even if he submitted it, it would get rejected because I was doing better than other patients and therefore didn't meet the requirements. I progressively worsened and kept asking about it, and they kept denying it until I got to a point where I went to the ER and had to be placed on a 5150 and go through the inpatient treatment before getting the outpatient treatment.
It's a really, really good question. That's where we look back at the definition of medically necessary. That's a boring legal answer, but that's where we'd argue that if your condition, if your symptoms rose to the level where an IOP would be reasonable and necessary to protect life, to prevent significant illness or significant disability, or to alleviate severe pain, then it is something that you'd be entitled to. So in the case of someone who is experiencing sort of intense suicidality, maybe some other depressive symptoms, I would imagine that that's probably severe pain, and you might have a reasonable risk that this might affect your life, and an IOP might be a reasonable and necessary way to protect your life and to alleviate that pain. And so that's what we would argue in the appeals and state fair hearing process, if they were denying it, as you're saying. So that's where that standard would come into play. So hope that answers that question. Any other questions in the chat? Sorry, I can't see the chat on my screen.
Oh, you're okay. I think that's it. Just a logistical thing about where this is going to be uploaded, but I'll handle that in the chat.
Cool, thank you. Oh, I have another one, another hand.
Yes, thank you. There was a question in the comments about how does any of this apply to clients that may not be willing to engage in services?
Well, that's a really interesting question. And it is a very tough question because I face this often when I am working with kids whose parents might think that they need treatment and the kid does not want treatment. But it also happens in the case of adults, of course, who maybe from the outside seem to appear like they would benefit a lot from services, but they're just not interested in engaging. All these services have to be voluntary. So the county and or the managed care plan is not allowed to force an individual to receive treatment. So when I'm talking to a client or maybe a client's parent, the parent says that they want their kid to get services, I then ask the kid, like, is this something that you might be open to? And if it is, then we can go forward. But if it isn't, then the county won't even really engage because the individual person has to be voluntarily accepting these services.
Thank you.
You're welcome.
Sarissa has her hand up as well. I'm not sure, Sarissa, if that was from before, or if it's a new question, but go ahead and unmute if you have a new question.
New question. It's about the youth under 21.
Mm-hmm.
What about the policies, or I don't know if it's a policies or if it's an unspoken norm, of children like 13 and over making their own mental health and medical decisions? How does that apply in this situation, especially understanding the context that mental health can impair judgment or decision making thinking, or your thought processes, or your ability to understand if it's actively your mental health condition is actively engaged in impairing your mental processes. So how does that work?
Yeah, that's a very good question. Um, it still requires it to be voluntary. The state is generally over the last few decades moved away from any kind of commitment or involuntary mental health treatment. And it can be tricky when there's a child or a family member who from the outside clearly appears to need services, but they are maybe even because of the diagnosis they have, that diagnosis itself is preventing them from knowing and understanding their condition and engaging in services. It still has to be voluntary. And so that individual, and you're right, when someone turns 13, just about all mental health clinicians are going to be asking that the child now for consent, because at 13, generally speaking, the child has the capacity to understand what's going on and consent or refuse treatment.
So is there anything that a parent can bring, say like psychological or neuropsych testing, like their IQ levels? They may not be labeled as intellectually disabled, but they are, say, like 1 point above intellectually disabled. Would that be relevant data to help that, or no? Is that not relevant in this situation?
I think a lot of these decisions are made on a sort of individual clinician by clinician basis. So one clinician might review that and say, "You're right. Like this child does not have the capacity to make their own decisions." And so we're going to ask a parent or a loved one or whoever their legal guardian is for consent. But yeah, I would imagine that's how it plays out. I'm sure there are systems where there are policies in place, whether it's internal to the county or within a healthcare system like Kaiser or like Anthem Blue Cross within a medical practice themselves. They may have different rules where they say, no, it's a hard and fast rule where we will not treat someone under the age or over the age of 13 without their individualized consent. So it can differ, and it probably just it's a case by case kind of thing. Okay. Any others before I move on to grievances and appeals? All right. Okay. So we got us all revved up on what people are entitled to and how that might differ from reality. And now let's talk about how to fight back. So the basic order of operations in like the simplest sense is you have to file a grievance or an appeal before you request a state fair hearing. There are some exceptions to this, but 99.9 probably % of cases look like this. If you file a state fair hearing before you file a grievance or an appeal, either with your managed care plan or the county, it'll be rejected. And the judge will say, sorry, I have no power to do anything because you haven't gone through that process first. And so you need to make sure that that comes first. So we'll talk first about grievances. And this slide is overwhelming, but yeah, this slide says that a grievance is a dissatisfaction about matters relating to services. And so that is, you feel obviously disrespected by your provider, or the quality of the services you're receiving is poor. You're your provider is saying some kind of weird things to you. There's some kind of interpersonal relationship problem. I've had clients hear very strange things from therapists before that made them feel very uncomfortable or triggered them, triggered some trauma response that they've had in the past. And in the grievance filing response within the mental health system is different depending on whether you're in the managed care system. We're talking about managed care, Medi-Cal mental health, or we're talking about county mental health. In the managed care world, both of them look like this, but the timing is a little bit different. So you file your grievance, and you can usually do that over the phone or in writing or sometimes online. But if you were to Google like Sacramento County Behavioral Health Appeal, or I'm sorry, Sacramento County Behavioral Health Grievance, they should pop up with a form and how to submit it. You file that, then you'll get a letter usually within about a week that says, thank you, we got your grievance. And then someone will look into the issue. And then within 90 days for counties or 30 days for the managed care plans, they have to give you a notice of their resolution of your grievance. So they say, usually, unfortunately, what happens when you file a grievance is they say, I'm so sorry this happened. We really try to do our best. Hopefully this doesn't happen next time. But sometimes there's real changes that are made. Sometimes patients with an issue provider, and after enough people have complained about a provider, that plan may no longer work with that provider anymore. Or if there's a problem with their system, they may find that out through a number of grievances and resolve that system. But generally speaking, a grievance can be filed at any time, and it has to be looked at by the county, and you'll get some kind of response. I think the more interesting challenge is called an appeal. And so an appeal is the review of an adverse benefit determination. And these are very specific things laid out in state and federal law. One type of adverse benefit determination is if your grievance or appeal that you filed was not responded to within the right time window. Another one is a limitation of a service. So let's say I was getting therapy twice a week and they cut me back to once a week, I can appeal that. Disputes about financial liability. So if they say, oh, you're actually responsible for paying a portion of this, that's appealable. If they stop a service, we're getting twice a week therapy and they cut it off altogether, that's appealable. If they deny a service, so you say, hey, I want therapy, and they say, sorry, we don't have any therapists, or sorry, we don't think you need therapy, or your doctor submits a request for residential treatment and the county says, no, we don't think you qualify for that. We don't think your needs are severe enough. That's a denial. And then the one that we talked about before, a delay in service. So this is where the plan fails to provide you with the provider within those time limits we talked about earlier. So if you ask for a psychiatry appointment and they don't give you one within 15 days, that's an adverse benefit determination that you can appeal right away. And until very recently, the fact that those timely access standards are delays was a little bit of a question. We sued the state over this, and the state issued new guidance to the counties that now says that if a county or a managed care plan does not provide a service within the 10 or 15 business day window that we talked about earlier, that is an adverse benefit determination that is appealable. And then what do you do when there's an adverse benefit determination? How do you file that appeal? So you're supposed to be given a notice of the adverse benefit determination. It's called an NOABD, a notice of adverse benefit determination. It doesn't always happen. Some counties are better at it than others. We have a lawsuit against Sacramento County because they had a history of not being so good about this. There is two types of appeals. You can file a standard appeal or an expedited appeal. The standard appeal has a 30-day response deadline. So the county must respond within 30 days. An expedited appeal, the county must respond within 72 hours. And in order to be eligible for the expedited appeal, that's where you see the little purple arrow there. Waiting for the full 30 days must seriously jeopardize the person's mental health. There's more to that quote, but effectively, waiting too long would have some detrimental impact to your mental health. And counties will deny, you'll file an expedited response, and sometimes they agree with you and they'll treat the appeal as expedited. Sometimes they'll disagree with you and they'll send you a letter within those 3 days, within that 72-hour period, saying, sorry, we're going to process this in the normal appeal timeline because we don't think your condition is severe enough. And then at the end of that 30-day or 72-hour period, county is required to give you a resolution, whether they're going to uphold their original decision, say, sorry, we don't agree with you again, or whether the county or the managed care plan is going to overturn their previous decisions. They're going to reinstate the services that were cut back, or find your provider that can see you sooner, or approve a service that you've asked for that they've denied. The two blue boxes on this screen, they refer to the timelines after you receive the notice. So like I said before, it's kind of rare for these counties to actually send these notices, but if they do send them, you must file your appeal within 60 days of the date on that notice. And if you want to continue services, like let's say you've been getting therapy twice a week, every week for months, and they say, sorry, we don't want to do that anymore. If you want to continue those services while you wait for the appeal and maybe wait for the state fair hearing, you must file that appeal within 10 days of getting the notice. So just realize that there are timelines if they do issue a notice. If they, of course, don't issue a notice, I always recommend just follow the timelines anyways, just go as fast as possible because you want these services as fast as possible. But if they never sent a notice, they can't technically ding you for not following the deadline. And then once you either file an appeal or a grievance, you get to go, and they don't resolve the issue after the appeal or the grievance. I should mention that. If they solve the issue, great, you don't have to go to a state fair hearing. But if they don't, then you request a state fair hearing. And a state fair hearing is the review by an administrative law judge who works for the State Department of Social Services, and they will host the hearing where the judge presides over the hearing. It's a relatively informal setting, so it's not like you're going to court. It's either by phone, which is probably 90% of these hearings, by Zoom, or in person, and it's usually like in a county conference room somewhere. And in those hearings, it'll be the person who's requesting the hearing, so yourself maybe, any person that individual wanted to bring with them, whether it be a witness or a support person or their lawyer or whoever else, they could be there as well. And then there'll be a judge, and then there'll be a representative from the county, usually called the county hearing representative. And then there will be sometimes a witness that the county's planning on using. And so it's relatively short. Most of these hearings are scheduled for 30 minutes to an hour. If it's an IHSS issue or it's a very, very complicated issue, sometimes they might block you out for 2 hours. But generally speaking, these are relatively short hearings where the judge is trying to get through the information pretty quickly. But you have the opportunity to raise the issue, to show the judge that that you've asked for a service and the county didn't provide it to you, and here's why you're entitled to it. And then the judge is allowed then after that to determine whether you're right or whether the county's right or whether your managed care plan is right. And so if you said, I want to go to a residential treatment center, and the county says, sorry, we don't have that, and you appeal it, and the county says, sorry, we still don't have that, you could go to a judge, and the judge could say, actually, this person meets the criteria of medical necessity. They need that residential treatment center. County, you are ordered to provide that service to that person. I'm not going to say that this is a perfect process in any way, because I have had my fair share of experiences in this process where the judges just don't understand the situation or just don't care. But the same time, there are judges who do understand and do care and will resolve some of these complaints. And so you can file these hearing requests either online, which is what I always recommend doing, because you can do it without an account on the State Hearings Division website, or you can do it by phone. And you generally are waiting about 90 days, if not longer, for a hearing date. And then you have the hearing date, and then it's usually still another few weeks before the judge issues their decision. And it makes this process not so effective when we're trying to challenge a timely access issue, because if you are entitled to a therapy appointment within 15 days and you appeal it and the county still hasn't provided it to you, and now you're going to a state hearing, the judge might not decide on this issue for 3 or 4 months. And then at that point, maybe you have your psychiatry appointment, maybe you don't, but it does really frustrate that process and make it almost not worthwhile for many people in many circumstances to even go through it. But for those of you who can, or for those situations where it makes sense to, I will generally recommend my clients go through this process, whether it be by themselves or with representation from myself or one of our other advocates here at Legal Services. There is also the option here, as it says, for an expedited hearing. They very rarely grant them. You have to have documented evidence that this person is like an imminent suicide risk or imminent risk of death or serious bodily injury if they were to wait 90 days. I've had what I think are very convincing cases where they deny expedited review. So that is what it is. The last thing I'll mention here on state hearings is that you must request the hearing within 120 days of the appeal or grievance resolution. So that's 4 months, effectively, of the date that they responded to your appeal or grievance. If they never respond to your appeal or grievance, great, that clock never starts ticking. But if they do, there is a sharp timeline, and they will throw your case out if you don't meet that timeline. Okay, and then I said the last thing I'm going to mention about this, I think probably at least once already, but one more thing I'll mention about state hearings is that the judge wants to see documented evidence. So you obviously can provide your own testimony just by talking to the judge during the hearing. The hearing's recorded, the judge is going to listen to you. That's helpful information, but the most helpful information is always going to be something in writing. And so getting a letter from your therapist or from your doctor saying you need a service is almost always more convincing than you just telling the judge that you need the service. Even better yet, evidence that you maybe even wrote in writing to the county or to your managed care plan saying, here's the service I want, here's why, here's the doctor who says I need this service. And then them not responding or not providing it to you, that's really, really good evidence and may convince a judge to side with you. But, and if you were to be my client or you were to be one of my other colleagues here, clients, we would walk you through this and talk about what would be good evidence to bring to a judge or to the county during the appeal process, how to get that evidence, what might be a better solution, maybe if the hearing and appeals process maybe isn't the right solution for you, depending on timing or something else. But this system does exist for a reason. You have an entitlement, you have a right to receive these services. And so if you're not getting them, this is the way of challenging it. So when you're if you're working with clients who may be struggling to access mental health services, I generally am looking for a few things. I want to know, where is this person, this client, in the timeline of accessing mental health services? Have they made the request? Have they had an assessment? Do they have a treatment plan? And have they started services? Because it differs what to do next. If that person's never requested services, let's start there. If they have requested services but they never got an assessment, let's ask the county or the managed care plan for an assessment. That's usually the first stop. The second thing, and that's exactly what I said, who do they contact when? I've had clients who very reasonably believe that they are asking for a mental health service, but it turns out the county behavioral health office has other clinicians that are not with the county in the same office as them, and they think they're asking for mental health services, but they're actually asking someone who's not the county for that service. So making sure that they are actually asking the right place. Does the client already have an assessment and or treatment plan? How old is it? If you can get a copy of it, great, because if they have an assessment that's relatively recent and it says they need 3 times a week therapy and they're only getting 1 day a week therapy, like that's pretty easy. Like that's written down. I can challenge that quite easily in an appeal or a hearing. And that may be something the county will provide pretty quickly. And then are they actually receiving the services listed in the treatment plan? If not, why not? And does the client agree with the assessment? Because sometimes assessment's done and either it's too vague to be helpful or it is kind of off the wall. It doesn't really make sense for the person's situation. And maybe getting a second opinion and getting a new assessment done might be what you need. It could also be that the last assessment that was done was 3 years ago and your situation's very different now. You may need very different things. And so if your conditions change, you can always ask for a new assessment as well. But these are kind of just like what to look for to keep an eye out for these issues. And then here's the types of things that we work on. Of course, if you want to reach out to me and say, hey, I saw you at this presentation, I had a question about this, shoot me an email. I'll show my email on the next slide. But if you are talking to someone and you're trying to decide whether this is a good referral to us or not, here's the general categories of mental health cases that we spend time working on. Denials of services, kind of self-explanatory. Limitations on services, that's like where they're reducing the number of sessions you get or something like that. A lack of services, so you need your IOP program, but your county says we don't have that here. A delay of a service, that's where they're not providing within timely access standards. And then any other access barrier. Someone needs transportation, they need some sort of accommodation for a wheelchair or a support animal of some kind. Those are things that you can ask for and are generally things that Medi-Cal recipients are entitled to. So if any of these things are coming up, please send them over to us. If you yourself are stuck in one of these issues, please come talk to us. Here's our phone number. You can find it on our website. And then here's my email address that comes right to me. If you've got a question, if you're working with a patient and they have questions and you're like, hey, I don't even know where to start. Are they someone that's appropriate to refer to you? Are they not? Is this something that you would handle? Shoot me an email and I should be able to answer your question. Okay. And that, my friends, is the end of my presentation. So I am open to questions about this last section, any of it, something totally weird and interesting that you have a question about. We got 30 minutes, so feel free to ask questions now if you got them.
There's a question in the chat from Claire. It says, I'm interested in hearing, if possible, how potential psychiatric patients can gain witnesses to attend particular appointments. I found this very difficult, calling many different agencies, searching for a willing person with zero luck. I attended an unwanted appointment with an SSD psychiatrist with good outcomes, in my tiny opinion, without a witness.
How do you get a witness to attend an appointment? And could you repeat the beginning of the question? Were they in a hospital setting?
Claire, would you like to come off mute and that way you can explain more thoroughly and kind of give your context and example?
Sure. Can you hear me?
Yeah, I can hear you just fine.
Okay. I was trying to do the video too, but for some reason my video thing won't work. No, I wasn't in the hospital. I was, I had some shoulder and neck issues and had for the second time in the final time tried to file a Social Security disability for those physical issues. But because time where I dealt with Social Security disability in, I think, around 93 or 92, 93, somewhere in there. And I didn't even file this paperwork back then, but it was in my record, and I had a short amount of time on Social Security disability due to psychiatry. When I filed for neck and shoulder issues, Social Security wanted instead to examine that. And, it took a long time to go through their system. When they first suggested something like this, I'm like, oh no, that's not why I filed. This isn't fair to me. And so the first time I filed, I said, okay, forget it. I'm not going to do it. But then the second time I filed, I went through it. And, when they wanted to do it again, I'm like, okay, I have to deal with this. I've heard this before from people, you have to go through rather than, try to forget, abandon or whatever. You have to go through the system. So I called different local agencies that I had known about, legal services, not legal service in Northern California, unfortunately, back then, but like Resources for Independent Living and places that I had known about. And nobody would go with me to that appointment. But you were mentioning witnesses earlier in your talk. So that's why I asked, because I would not even believe that was possible from what I went through.
That is a very good question. There are, as far as I know, I don't know of any entities out there who have people who can or like volunteering or employed to become witnesses. When I said witnesses, what I was meaning was someone who is just in the room already. So a friend or a family member who may have just seen what had happened. And that could be theoretically anyone. But there's not an entitlement to have a witness be in the room during those appointments. So
Thank you.
yeah,
I think it would be appropriate. It's kind of scary when a big system decides to do something like that.
yeah, seriously. And we do Social Security work here at Legal Services. I don't spend much time on Social Security issues, but there are people here who do.
Right. Thank you.
Welcome.
We have a couple hands raised. We also have a quick question in the chat from Zoe asking if there's an organization like yours in Southern California. David provided one resource, but if you have any others that we can share with Zoe or others in that region.
Yeah, so there's a legal aid who serves technically every inch of the country. It's a federally funded program that's been around for the last 70 plus years. So there definitely is, depending on where you are. Where I would recommend starting, I mean, you could just Google like legal aid in my area, but all of our health programs in each of the various legal aids in California all team together and have meetings and stuff with a consortium of us that we call the Health Consumer Alliance. And so if you Google Health Consumer Alliance, HCA, and you were to even call the number on there, they will route you to the appropriate health consumer center at a legal aid in your area.
You said that was Health Consumer Alliance?
Correct.
Okay.
Yep. Okay, and then Topher, I see your hand raised.
Can you hear me?
I can hear you.
I am just curious. So for appeals, if a specific individual, like county contracted provider, were to give somebody the notice of adverse benefit determination, would that appeal be with that specific provider or with the county itself? Like if the client were to win the appeal, it's like overturned, and would that individual provider be the one that's required to provide services, or would it be up to the county to make sure that that client gets services even if it's from like a different provider with providing similar treatment?
Super good question. And that's relevant in many of the counties where they have this kind of sort of strange subcontracted system. So some counties are small and they only have one place. There is like Humboldt County just like employs a number of therapists and psychiatrists that just work for the county. But many counties like Sacramento will use this like clinic model. So in Sacramento, we have a number of county clinics that are all county mental health providers, like Stanford Sierra and El Hogar and Turning Point. All of them operate as effectively county operators. And so when they deny something or they delay something, they're responsible for issuing that notice. But then when you appeal it, it goes straight to the county. So it goes above them. And if you're asking for a service, the county is responsible for providing that service. And so If the county can provide that service within the clinic you already are in, great. If they have to go elsewhere, they go elsewhere. If they don't even have anyone in any of their clinics, they got to contract with someone out of network, and they're still bound by those same timelines. So hope that answers your
That's
question.
really helpful. I guess follow up on that, like so it sounds like it would be up to the county to decide. They could, if that provider can provide the right treatment, it sounds like the county could tell that contracted provider, like, you need to get the treatment for this person, or they could make the decision to decide, like, we'll go and find another place for this person to get treatment at.
Absolutely.
Okay, thank you.
I have a question.
Okay.
I have several questions. Kind of going back to the assessment. So, I'm just going to quickly summarize. So, I have a disability. I receive SSI for it, but I cannot find a provider to treat the condition that I get benefits for. So I learned today that my mistake was, and correct me if I'm wrong, is even though I was identified through SSI for the disability, the doctor has not identified me. And I guess I'm getting that correct. So I should have asked for an assessment instead of going in saying, "Hey, can you treat me for this condition?" My first thing should have been, "Can you assess me for this condition?" Correct? Am I understanding that? Because then they have a legal obligation, right, to treat it, or say, "No, we don't treat that here, find somebody else," or what?
That would be technically, if you ask for an assessment, that's going above and beyond. You don't have to use any special words to say what you need. The county should automatically, or your managed care plan should automatically hear, "I need mental health care," and immediately put you on that timeline and get you the assessment first.
So they're not, and I have not received mental health care in almost probably 5 years, because nobody's doing an assessment, and I didn't know to ask for one. So I guess that's what I'll do, because what I'm finding is they're not even charting in my notes my request. And so I guess that's my next question. What do we use when they're not documenting it to trigger an adverse benefit reaction for us to even escalate it?
Yeah, so that's such a good question. In my practice, I will write a letter to the county that says, I requested this service during this meeting with the county, or I requested during a CFT, or or my client requested it during her last therapy appointment. And I'm just documented here in writing that this is what happened. Please provide an answer within whatever the authorization window is for that specific service.
So the county, is that the Board of Mental Health, the Board of Soups? Like, who is that?
Good question. So again, I'm assuming in this context, or this hypothetical, we're talking about a specialty mental health care service, a moderate to severe treatment through the county. But if it is, then you'd be sending it to the county behavioral health department, and most county behavioral health departments have some kind of like quality review or like grievances and appeals office that like takes these letters. So if generally what I'll do is I will go to the county behavioral health's website, and I will look up who's reviewing their appeals and grievances, and send it there. And that generally works.
Okay, that's really good, because I'm trying to break out of this cycle. I guess my next, and I don't know if I should talk to you guys or Disability Rights California. I've been torn, but I personally received ECT treatment, which is a form of a treatment for mental health conditions. Part of the side effects are memory issues. I'm asking for an accommodation of either I record my doctor's appointments, or a video, or wear like a body camera. And I'm telling them, like, I had a memory test done through Stanford. I have relevant data that shows that there's a memory impairment as a side effect. How do I get those accommodations that I need? Because I am struggling to remember what we talk about, or my sequencing of events of the things we talked about are distorted. That in itself sometimes is a side effect from mental health, but it's also a side effect from the ECT. And so knowing that I'm struggling, so I want to replay it so then I can be like, oh yeah, I did get that wrong in my head. This is the right order we discussed of things. How do I get accommodations when a doctor that I've asked have literally looked like I was a three-headed dragon? Like
So
seriously.
yeah, I mean, you're obviously more than welcome to just contact us and we can talk it through in your specific case. But generally speaking, any disability related accommodation is part of the American Disabilities Act and a number of both state and federal laws that entitle individuals with disabilities to reasonable accommodations. And so what you'd ask for is what's called a reasonable accommodation for your disability to allow for you to use a certain device or to make a certain change to their system that would maybe make it would make it easier for you to access the service that you need. But it's really more of a disability issue than it is a mental health access issue. I mean, obviously they're related,
Oh,
but
okay. Yeah.
but yeah, it's much more of a disability issue. It's something that we can talk about here at LISNIC. We do a lot of disability rights work.
Okay.
Disability Rights California, also a great
Well,
resource.
I keep running into the HIPAA violations and violating other patient rights, and there could be other patients talking louder in the other room. You know, a lot of things. I would appreciate that. I do have another quick question, if it's okay, or do you want me to ask in a few?
You want to? I'm gonna take a pause on you. We'll go to somebody else, and then if we have time, which we probably will, we'll come back.
Okay, thanks.
Yeah. I see a hand from Iris.
Hi, Ted. Thank you. Yes, my name is Iris, and I'm a patient advocate in San Diego County. I work with Topher, who was just asking a question a minute ago. I have a question regarding state fair hearings. You described that in the state fair hearing, there's a patient who might have a third party, I'm guessing perhaps a witness or a family member or something like that, attorney, and then that there's a judge and that there's a county hearing representative and their witness. Two questions. Who is typically the witness that the county representative brings? And then the other, I guess the bigger question is, we, like our office, if our client has a NOABD and we investigate their appeal and their appeal is denied and therefore the provider met the criteria to issue that NOABD and the patient has the right to file a state fair hearing. We haven't experienced that state fair hearing in our office. We want to, be knowledgeable about it in case that does happen. I'm confused about the state fair hearing process. The patient is getting a hearing to argue with the county and not the provider, or it's kind of like confusing to me. Why wouldn't the provider be in that state fair hearing instead of a county rep?
Yeah, great question. So if it's basically you against the insurance company, and when we're talking about Medi-Cal mental health, that insurance company is either managed care plan or the county. And so in an instance where we're talking about the county, like we're talking about here, the county sends a representative. They have an office of people who just represent the county in these types of appeals. And they're usually not lawyers, but they sort of act as the county's lawyer, for lack of a better word. And the question is usually, is the county as an entity doing what it's supposed to? If there's an issue with an individual provider, the county is responsible for that provider. And it may be necessary to bring the provider in as a witness. But in my experience, what the county is more likely to do is cite to medical records or a letter from the provider or other evidence that the provider has written instead of bringing the provider into the room to actually do the verbal testimony. There is technically the right and a process for subpoenaing witnesses. So if someone doesn't want to show up and you need them to show up, you could theoretically subpoena them to show up to one of these hearings. We generally don't advise it because forcing someone to speak at a hearing when they're not wanting to is not usually in your best interest, but obviously it depends on the situation. So that's an option as well. But yeah, the person who the county is normally bringing, I mean, if this is a different context, but if it's IHSS, it's usually the social worker who did the assessment of the person. In the mental health context, I have seen like the head of the clinic show up to hearings. So I've seen like a client in think Ventura County, and the head of their clinic that the person was assigned to within the county, they showed up to say, no, sorry, we've tried everything, but this service is not actually necessary. We've done all these reviews. Here's all this medical evidence of why this person does not actually need this thing. And so that person was the witness for the behavioral health department.
Have you ever seen the patient advocate themselves in the hearing before?
The patient advocate, like patient's rights advocate that
Yeah,
they got
yeah,
from, okay.
yeah.
I have not. I work with some of the patients' rights groups up in Northern California, and I have not had the opportunity to have them as a witness in any of our hearings before.
Okay. Thank you so much for your explanation, Ted. Thank you. And thank you for this presentation too.
You're welcome. All right, Michael, I think you're up next. Oh, Michael, I'm sorry, unless it's just me, but I think there's an issue with your mic. Sometimes I have that issue and I have to like log out and log back in, or unplug my mic and plug it back in. Okay, well, we're waiting for Michael. Is there anybody else?
I do. I have a question.
Sure.
Can medical records be used to trigger the adverse benefit, like their response, even though it wasn't submitted to the insurance to get that, or the county? Can we use medical records if we want to trigger an adverse benefit to then be able to file the grievance or take it to hearing?
Yes, and I do that frequently. Like sometimes in the medical records, it'll say patient requested X service. I think X service is appropriate for this patient. And then nothing happens after that. That's where I would argue that that was a formal request for the service, and the county never responded to that request, and we're appealing that failure to provide or respond.
Okay, awesome. One more question about the administrative law judge. Are
Okay.
they like real, like, I don't know the technical term, but are they like real judges, like legitimate judges?
No, I think they're all lawyers.
Oh, okay. Okay.
And they are employees of the state. And so
Okay,
all
so
they do every day is do, and they're sort of broken up by different subject areas. So the person you'd likely get in a mental health case almost certainly only does Medi-Cal healthcare service denials and appeals and that sort of thing issues. So they'll be sort of familiar with the issues, but there's always a little bit of educating to be done.
okay, awesome. So who oversees them? Because I know, like in courts, like family court, things of that nature, they have the commission of, for judges that would oversee their, would oversee them to make sure that they're following the law, and their ethics. So who would oversee the ALJs if should a complaint need to happen?
There are presiding judges. They're the sort of head judges within the state hearings division, who technically could, like, they're effectively these judges' boss. So they could pull a judge off a particular assignment. They could, I presume, like theoretically fire them, or give them new training, or whatever else might be necessary.
Okay, cool. Thanks.
You're welcome. Michael, let's test out that mic.
Can you hear me now?
Yeah, perfect.
Oh, cool. Yeah, firstly, thanks for this wonderful presentation, Ted. I apologize, I came in a little bit late and I don't know whether you covered this. And my question, actually, I've got like a two-part question. The first part is, does this apply to clients or family that is on private insurance? Because a lot of things that you talk about, it kind of I understand it applies to the public insurance, like Medicare, Medi-Cal, but we've got people in the county that is mostly on private insurance, and I was wondering, does the appeal process and all those kind of stuff any different?
The system actually looks very different, because it's all handled within the managed care plan. So
Okay.
whether that's an employer provided plan or a Cover California plan or whatever, the planner is responsible for everything from individual talk therapy on the mild side to like a residential treatment center. And all the plans have different laws that apply to them. Some are federally regulated, some of them are state regulated. Some of them have oversight by the federal agency that does like Medicare and Medicaid plans. And so the rules can change wildly between what your rights are to appeal. But generally speaking, the grievance and appeal process at least is available in just about all of these types of different plans. The definitions are a little bit different, the process is a little bit different, but that piece is definitely the most similar. And in some of these systems, you have the right to an ALJ. In some of these systems, you don't. In some of these systems, you have the right to an independent medical review by like an outside physician or clinician, and some of them you don't.
Okay, sounds like another day for a different presentation.
Yes, a whole totally different thing.
Yeah. So the second part of my question is, do you happen to have a compiled list of, the different patient advocacy groups, um, throughout California?
I don't have one in front of me, but if you go to the Health Consumer Alliance's website,
Okay.
they will. They're the group of all of us legal aides who have health programs, and so there's one that represents every county in the state, and they will get you the right place.
And they will have information on if you're part of the private insurance category, and I take it Legal Aid Society would they help you with that situation?
Yep,
I wonder.
I work with people with all sorts of different health insurance and combinations thereof. I have clients who have a private insurance plan through one place, like maybe through a parent, and then they have Medi-Cal in addition to that, and they might even have a third or a fourth plan that make things like a fun little puzzle. But yeah, all of the above we work on.
Okay, that's super helpful. Thanks.
Okay, I got a few people with hands. I don't know who's next. I'm sorry. I'm going to go to Topher.
Yeah, I have a follow-up question, not about a different topic, I guess, but sorry if you already addressed this. For grievances, after someone files a grievance and receives the result of that, does a state fair hearing also apply to that as equally as much as an appeal? And like, if so, I guess what would that look like? Is what type of decision would they be reaching in the state fair hearing?
Oh, such a good question. The grievance, yes, you have the right to a hearing if you don't get a satisfactory response to your grievance. But the vast majority of the time, the issue that people are grieving about is not something the judge thinks they have any authority to fix. So if you said like my provider was like really rude to me and you give a number of examples, that would be eligible for a grievance. It would also be eligible for a state fair hearing. But the judge would say, like, there's nothing I can do to force the provider to be less rude to you. If there was an issue of discrimination where a provider or some county worker or administrator of some kind was discriminated against you based on like your race or your sex or your gender identity or one of the above, there's a different process for resolving those types of issues. And I still think that a judge would, in the state fair hearing context, even in that situation where it's like clear that someone's violated the law, they wouldn't have the ability to force the county to do anything differently. So it's really mainly, the state fair hearing process is really mainly for appeals, even though technically it's open to grievances too.
Okay, thank you. That's really helpful.
Yeah, you're welcome. I'm gonna go with, is it Gyro?
Yes, Jairo, thank you so much for the wonderful presentation, Ted. So I just want to ask something. On one of your earlier slides, it was mentioned that the deadline for grievances is 90 days, but it's my understanding that that changed to 30 days in January. That is what we're doing in San Mateo County.
The grievance response deadline has changed.
Yeah, the deadline to complete the investigation into a grievance and to, provide an outcome to the folks filing the grievances was reduced from 90 days to 30 days, January 1st.
That I will update my PowerPoint. I'll make sure that that's corrected. Yeah, that very much might be. The last time I very infrequently file grievances because they don't generally result in resolutions that my clients actually need. So, but that's a really good point, and I will make sure to update that. Thank you.
Yeah, you're welcome.
Claire?
Hi, thank you for your presentation and for answering all these questions. I know this is complicated. And I have a really complicated situation that started last year that I tried to correct with my medical provider. And it didn't get better. But also on the side, not only did I file grievances through the medical provider and go through a lot of complicated paperwork and dealing with a lot of different people with their appeals and grievance center in San Diego, but I also had filed with the California Medical Board. And the California Medical Board came back saying a patient can write a statement, like a certain amount of words, like 250 words, and have it placed in the medical record. This is by, I guess, California medical law, into the medical record near where this person has put their information. And so I did that. And as far as I know, the system has completely not done that, right? I've, sent it to various people. I called, the system and asked where to send this worded statement to place. I have dealt with UC Davis on stuff like this, the HMO. I was in an HMO at UC Davis for a while, and they have a very formalized process to do all this stuff. And I'm not recommending that their system, but they do work on edits their medical record. This other system, and maybe times have changed because modern people do things differently. It doesn't appear that they did anything, they would do anything for the patient. It was really surprising that this would be so difficult. Or just, why would that be a challenge to put the patient's worded statement near the doctor's statement? That does not make sense to me. And
Yeah.
how would you approach that when they ultimately don't do what is California health code allowed, or law or whatever it is?
So you are right that generally speaking, people have the right to make what they're called like addendums to their medical records, where they add a statement to the medical record, especially if they're refuting something the doctor had said. I have not had a situation where a doctor refused to put one in.
I don't think it's a doctor.
I'm sorry, you're right. Of course, it's like
the record editing,
the record keeping office or whatever, right? Yeah.
Exactly.
Yeah, in my experience, they just have happily put it in because it sort of doesn't mean anything to them. Like they're like, okay, fine. I also have not recommended that my clients fight these issues too much, just because the end result of adding an addendum is, at least in my experience, has not materially affected my client, either positively or negatively. And so I've recommended just not doing it, because it's usually not going to resolve the issue that they're actually coming to us about. But I don't necessarily know who would enforce that. Obviously, you could sue the doctor privately, but it doesn't really fix the issue quickly or easily. And I don't think that there's any oversight agency that is tasked with the obligation of enforcing those rules. So I unfortunately don't think that there is an option, but I also have to admit that this isn't something I've looked into thoroughly either.
Thank you for answering that. I think you're right. I think a lot of these things, it just kind of, you look at it as, bad wastewater or something, like, oh, well,
Yeah.
I'm sorry I got involved with the system, right?
Yeah.
Thank you.
You're welcome. And Sarissa, do you have another question, or is your hand still up?
No, I think you answered all my questions. I appreciate everything. Thank you so much.
You're welcome. Happy to talk. And I think you were the last one. Was there anything else in the chat that I can't see some of these
I think I see one from Vanessa. How do you handle complaints about housing supports and FSP related issues?
Oh, that's a hard question. How do I handle housing supports? So many of the housing related programs are not entitlements. Um, some of them are and some of them are not. And so if someone already has housing and it's through one of various programs where you have an expectation that you're going to keep that housing indefinitely or for a specified amount of time, there's always going to be appeals processes and legal rights to that housing program. When it comes to like the CalAIM community supports, where there's housing related benefits, there's appeal rights and a state fair hearing rights, very similar to what we talked about here for them as well. And then full service partnerships, FSPs, things get a little tricky. So Vanessa, if you have specific questions, I really recommend reaching out to us directly because there's not one answer I can give to that. Okay, and I'm thinking that is all of the questions. So thank you all for having me. I love talking about this stuff. I'm happy these questions came in because there was a lot of really, really good ones and obviously some inspiration, I think, for future talks. So thank you, Cowvoices. Thank you, everyone who showed up. And I don't know if, Marco, you wanted to give a closing remarks, but that's my time. Thank you.
Thank you, Ted. Appreciate you being on here today.
Yeah, really insightful stuff. Thank you, Ted. Thank you, everyone who came and participated. I think this was a wonderful presentation, and I look forward to potentially hearing from other folks and getting them connected to you, Ted.
Sounds good. Thanks.